Good evening, everyone, and thank you for being here for our event, COVID-19, 5 Years Later, organized by the Chicago Forum for Free Inquiry and Expression. My name is Kellen Ryle, and I'm a fifth-year PhD student in the Genetics, Genomics, and Systems Biology program here at the University of Chicago, where I study evolutionary models of complex disease. Since the beginning of the year, I've also had the privilege of serving as the Biological Sciences Division Chair for the Forum Student Board. For those that may be unfamiliar, the Chicago Forum was established in 2023 to strengthen UChicago's longstanding commitment to open dialogue and the free expression of ideas. Our goal is to create spaces where complicated, uncomfortable, or controversial topics can be discussed with respect and genuine curiosity, teaching students to challenge ideas, ask difficult questions, and how to disagree in a constructive manner. I believe this event, reflecting on COVID-19, is a perfect embodiment of the Forum's ethos. The pandemic reshaped nearly every part of our lives, from science to public policy, to the economy, to education, to the workplace, and even to how we go about our daily social interaction. If there was one winner in all of it, it was most certainly Zoom. It also left deep disagreements in our society about how the decisions and our responses were made and what lessons we should take from them, with major tensions about public health guidance, the economy, personal freedom, and trust in institutions. As a major academic institution, UChicago students and faculty were heavily involved in the national conversation during the pandemic, from UChicago medicine experts advising city, state, and federal leaders on mitigation strategies, to Booth School economists helping shape national policy discussions in the context of lockdown trade-offs, and even to student groups like the Chicago Thinker gaining national attention for their criticism of pandemic policies. 5 years on, now thankfully far removed from the worst of it, this conversation gives us a chance to look back with clearer eyes. The goal of this event is not to rehash old debates or fight old battles, but rather to ask how we can respond better next time in future health crises, as no matter how hard we try, there will most certainly be a next time. How can medicine move quickly in the face of deep uncertainty, balancing speed with caution? How can authoritative institution gain the public's trust, balancing expertise with transparency and humility? How can governments most effectively legislate, balancing the collective good of public health with respect for individual rights? We're fortunate today to have a highly multidisciplinary panel of UChicago faculty members to help us answer these questions, including Dr. Elaine Allensworth, Director of UChicago Consortium on School Research and a nationally recognized expert in the areas of school leadership, improvement, and educational attainment. Dr. Eric Budish, Professor of Economics and Entrepreneurship at the UChicago Booth School of Business and a leading researcher in market design, whose work influenced COVID-19 economic policies and public vaccination adoption. Dr. Emma Levine, Professor of Behavioral Science, also at the Booth School of Business, whose research studies the psychology of trust, honesty, and decision-making, questions front and center clearly throughout the pandemic. And lastly, Dr. Emily Landon, Associate Professor of Medicine at UChicago Medicine and Medical Ethicist at the UChicago McLean Center for Clinical Medical Ethics, and an infectious disease physician who was a leading voice in public health policy at UChicago and the city of Chicago during the pandemic. Lastly, moderating the conversation will be Dr. James Woodruff, Professor of Internal Medicine, Dean of Students for the Pritzker School of Medicine, and a member of the Forum's Faculty Advisory Board. Thank you to all our panelists for their time and expertise, and once again, thank you to you all for joining us here tonight. We'd also like to thank the Zell Family Foundation for their support in these events. Lastly, I'd like to ask everyone to please remember to silence their cell phones. With that, please help me welcome Dr. Woodruff and our panel for COVID-19 5 years later.
Well, thank you, Kellen, for that set of introductions and also for outlining the goals of this panel. We'll be revisiting those goals hopefully regularly during our discussion. Just to lay out sort of the general structure of our conversation today, we'll spend about 45 minutes just sort of listening to some of the ideas that this group of experts and scholars have explored regarding the pandemic over the past few years. And then after that, for about 25 to 30 minutes, we'll spend some time answering questions from the audience and also from the virtual audience that's not necessarily here in the room. So to make the best use of our time, we'll just jump right in and actually have a prompt for Professor Emily Landon. So in 2020, you did a video for UCM that described what you thought would be the optimal way to be ready for the next pandemic 5 years into the future. We are now 5 years into the future. Emily, do you still feel the same way about some of the ideas that you outlined, which included electronic contact tracing, laundered personnel protective equipment, and a surveillance core? And if you feel different, tell us a little bit about that.
Yeah, so those three things are pretty fundamental to the basic method of sort of solving for addressing the beginning of a new disease or decreasing spread, right? I think blast from the past, you all remember flattening the curve.
Yeah.
So flattening the curve isn't about eliminating the curve or not having a curve. It's about spreading out the cases over a longer period of time. It's literally just buying time so that you can learn more, so that you can prevent some of the spread, hopefully, so that you can figure out who's at greatest risk, so that you can make more therapeutics or vaccines or whatever you need in order to help reduce the mortality or the negative consequences, and also so that healthcare can keep up with the cases, right? And so the three things you need in an SIR, an SIR model is simple, really basic epidemiology. You need to know who's sick. You need to know if there's pre-symptomatic spread. You need to know who's been exposed, and you need to know how to keep them apart, right? And so having things like a surveillance core or rapid scalable testing or like a testing platform and some public health systems that are ready and able to surveil for different diseases that can keep track of the testing so that we can rapidly scale new tests for new diseases so that we're able to identify who is sick. Contact tracing that's electronic, that doesn't require human individuals to be on the phone to recruit large groups of people to do that kind of work. Some way of being able to leverage all of the electronic devices and AI that we have to be able to track these things. And then PPE, I think, was one of the biggest problems in the pandemic and led to some of the measures that we needed, the lack of it, led to some of the measures that we didn't want to have to take. Things like not enough masks, not enough PPE for healthcare workers. We really needed to have reusable PPE for environmental reasons and because it's just more sustainable and easier to keep track of and like sort of a lot smarter than a bunch of things that expire and need to be disposed. So I think those three things really matter for us. And I wish we had them now. We don't. We started to have some of them. We have better wastewater testing, more scalable testing platforms, but we sort of stopped investing in them again. In the federal government has really cut back on their funding of those things and really pulled us back. So some of those things that existed, we built them, they existed, and now they're being dismantled. Contact tracing, there were some people in the market that were creating novel ways of doing contact tracing, and those have all sort of fallen by the wayside. And reusable PPE is a figment of everyone's imagination. We still use a lot of things that are plastic and disposable in the hospital. We just keep a little bit more of it around just in case we have a pandemic, right? Not enough to actually address a pandemic. But this is going to sound a little cynical because it kind of is. I think even if we had all of those things, I'm not sure they would work. Because one thing that I learned during the pandemic is that people really do not like to make sacrifices, especially if they aren't sure how big of an outcome it would be or how bad the outcome would be. And I think, the epidemiologists and experts that were in charge at the CDC at the very beginning of the pandemic, they knew we needed those things. They knew this was how you would respond and how you could flatten a curve or decrease spread and buy time. But for some reason, we just didn't invest in those things. And then we ended up getting behind the 8 ball and having to do really onerous and incredibly risky and very, very sort of high bad outcome things like stay-at-home orders, which we should never have needed for this pandemic, but we did because we did not have the other things in place, and we still don't. And I'm concerned that if we did, that people would still not want to adopt them. I look at the incident this summer where there was the camp in Texas where the authorities didn't want to order an evacuation, even though there was a high risk of flooding there, because they didn't want to bother anybody if it didn't turn out to be anything, didn't want to overreact. That's a real problem. We need to know and have a better understanding of when to overreact. But as a community, deciding together when it's okay to overreact and when it's not okay to overreact is not our strong suit. And I don't think we figured that out yet. So I would add to my list. in addition to those three things, we need some sort of community understanding, some sort of social pact or social contract of when it's appropriate to ask people to make sacrifices on behalf of the community.
Great, thank you. Maybe just a brief follow-up question, if I could, just about the work that you did. I know, Emily, you were out in front on TV, and I know you took a fair amount of flack during the course of the pandemic, and maybe even afterwards. I'd be interested to hear how that affected how you saw your work and how you executed your work, and has it changed the way you would do things in the future?
That's a great question. People, because I was in the media so much, people really were mad at me because their loved ones died of COVID when I took care of them in the hospital. And they were mad at me when their loved ones didn't die of COVID because they had to give up a business or something that went down because of a stay-at-home order. Everyone was angry about every sacrifice that had to be made. And they got really angry at public health. And I found that to be really challenging because public health isn't there to insulate us from having to make sacrifices because of illness. It doesn't do that. It just helps us to survive illness. And I think I wasn't really prepared for how little people understood that illness is really hard. As a doctor, I take care of patients every day. Like, all I see are people suffering from illness, right? So I know how incredibly difficult it is to survive and to sort of get through these horrible things that happen to people. They don't deserve them. No one in that hospital over there deserves to be there today. No one earned that or is in some way deserving of being as sick as they are. And so I see that people have to give up stuff every day and they have to live really difficult lives. No one is owed a smooth sailing path. And I was really surprised by how many people did not agree. There was, my son did not do great with e-learning. We're going to talk about schools in a second. Didn't do great with e-learning. It was a tough time for him. He's like a, middle schooler. And I was struggling because, there was a lot going on. And I never felt like that sacrifice was too much. I felt like it was a lot, but I felt like it was something everybody was giving something up, and that I felt like there was real value to giving up something for a community good. And I thought that, when people called me a Nazi and tried to, send me death threats and put me on a professor watch list, I thought, this is what you do when you have to say that, somebody has to give the message that we all have to stay home, even if that wasn't my preference. But that's a sacrifice that I have to make for the good of the community. And I think at some place in the pandemic, the scales kind of fell from my eyes, and I began to realize that there were a lot of people who did not share that opinion, who felt that there really wasn't much value to that, and they weren't willing to do that. And I don't know that I'm really over that yet. I felt it in a really personal way. I still do. I still get people who are mad at me. I still get some mean things. I'm not active on Twitter or X or whatever we call it anymore because I just got tired of it. I think that's a really hard pill for me to swallow. And that is something that I think affects how I live my life now. Not that it changes me from, I'm still going to say what I think is right. I'm still going to stand up for things. I'm not going to avoid any of that. But I think it makes me a lot more circumspect about whether or not people are going to be willing to do what's needed.
Thanks, Dr. Landon. We're going to move on now to Professor Allensworth. So my question for you, Elaine, is as part of the University of Chicago Consortium on School Research, could you tell us a bit about the student experiences that you studied through the COVID pandemic and since, and their implications for future pandemics?
Yeah, there's so much, and it's so complex. You have to think about different eras. So the first era was when the pandemic hit. That first year of the pandemic, when schools were closed, everyone has to all of a sudden figure out, how do we have learning from home that's technology issues, logistical issues, so much. And somehow we did it. I mean, there were huge efforts to get technology into students' homes, to increase access to high-speed internet. There still was a lot of inequity in terms of access to technology and ability to access instruction, but just the massive change that happened in terms of instruction that year is just mind-blowing. So then, for the first, certainly for the first several months, and then for many students into the whole next school year, the 2020-2021 school year, students were learning remotely, right? So they'd log in, to instruction. They'd have their classes that they would log into. Teachers had to figure out, how do I do instruction remotely? Parents had to figure out, how am I going to support students? And what we see in that time period is we see this kind of bifurcation in terms of what happened to students and how well they were able to do that. So you have some students that actually ended up getting higher grades and reporting some things were better. And then you had other students who then just, had a really hard time engaging. So you see, for example, all of a sudden, many fewer students are getting C's. You have a lot more students getting A's and B's, and a lot more students getting D's and F's. And when you look at, the overall experience of students, we see that students were reporting some things were actually better. They were reporting more support from their teachers and from their peers. So people were kind of rallying around, but instructional quality was going down. So harder to have discussions, harder to have really high quality, pedagogy. We also saw students who were reporting less support from their parents, which may sound crazy because parents were killing themselves during this time, but it was so stressful, right? That there was more conflict between students and parents. So students found parents to not be able to give them the support they needed as much. So you have all these things happening for students. We see, test gains, decline, so students were not learning as much. That's partly because it was a lot harder to do instruction remotely. It's also because students were not engaged in instruction for as much of the school day as they would have been if it was in-person instruction. It's really hard to stay plugged in to your computer all day long. There were different requirements at different grade levels. We found no matter what grade level, pretty much students were on for about 4 hours a day. For high school, that was way less than what was required, so a lot of students got counted absent, even though they were actually logged in. For the youngest students, they just had a really, really hard time engaging at all, and that's a really critical time for learning. And it also was a time, what I think we see now, this push, it kind of pushed these trends that we're using technology so much more in so many ways. And I think something, people, wanted to make sure students had access to technology. It was so crucial at the time, but it has really pushed these trends in terms of how much technology is a part of our lives. And we also see evidence that, increasing access to, to higher bandwidth, to devices, had negative consequences as well as positive consequences. It was necessary for learning then, but it actually comes along with a lot of negative consequences too. So that was then we had vaccines introduced, and some students started to come back to school in the spring. In Chicago, at least, it depended on what grade level you were in that you'd come back, but there was so much disruption still, and it was a lot of hybrid learning. So, it was still, it still felt, even though you had some students coming back for different periods of time, it was a lot of disruption. I think people thought then the next year would be the return to normal year, and the next year was the worst year. Outcomes actually declined even more in the return to school year. You had people who were exhausted, students, teachers, parents, and you also had these constant messages like, our test scores are going down, we better do something about it, putting panic, giving people panic and saying, oh, we better start this new tutoring program, bring in this new curriculum, do all these things. These are exhausted people at this point who are now being told, you've got to get students learning faster than you ever did, and now you've got to use all these new materials and figure out all this coordination. And, when people are like so stressed out, and when students are so stressed out, the thing they most needed, and I think school districts recognize that now, is to actually come back to an orderly, safe place where you knew what's going to happen. And instead, we had a lot of chaos. And that return to school year, remember, the pandemic is still going on. Yeah, there are vaccines, but people are still being told, if you have a headache, if you have a cough, stay home, or someone in the class gets COVID, and now everyone from the class has to stay home for 2 weeks. So there was still so much disruption. So in that year, we again see learning gains are low. We again now we see attendance really drop. So remember, during the first pandemic year, no one could go anywhere. So actually that kind of helped in terms of students getting homework done, and actually like logging in every day, even if they weren't logged in for 6 hours a day. But that next year, we actually see attendance just plummet. So a lot more students are chronically absent. And now all that increase in support that students reported from their teachers and their students in the remote year, all of a sudden goes way down. And teachers are, are reporting that they're in kind of this chaotic environment. Students are reporting that. They're also reporting further declines in terms of how much they feel like they're getting support from parents. And now we see time spent on studying, all those kinds of things go down. So that was actually the worst year. So now, as we're trying to recover, the year we're trying to recover from is that return to school year. So now, test score gains have kind of gone back up to where they were, but of course, students had a couple years of falling behind, so you see that kind of move through the system. And again, the youngest students had the hardest time engaging in remote learning. So you're going to keep seeing that as those youngest students kind of move through the system. High school students, actually, it looks like remote learning was actually pretty okay for many of them. I mean, obviously it's not as good as in person, but they were actually able to manage it. It was really, really big differences by students' age. And so, we're now seeing gains are similar, but students are still behind, and attendance has not gone back up. So we still have chronic absenteeism, and there are a lot of questions out there. Is it because of the new normal in terms of a lot of people working from home? Now it seems like, oh, maybe you don't need to go into school every day. The new normal in terms of, do you go in if you're feeling a little sick? Questions about, do you need to go to school if you can, do so much through technology, if you can turn in assignments and get assignments through your computer? And then, the law, the break, the issues with relationships, students being less likely to have in-person relationships, and all of the effects of technology in terms of things like having relationships, and which are so important for learning, and students' mental health too. So all those things kind of contribute. But what we are seeing is that there are things that schools can do, but I'll just stop there.
Great, Elaine, thank you. I think you touched on it as you were speaking about the issues that you've already addressed, but maybe you could just sort of pinpoint for us, what were the things that you think delayed sort of the pivot back to in-person education?
Yeah, I mean, I think we as human beings will tend to focus, if we're worried about something and we're concerned about that, we focus on that so much, we often don't see what else is around. And it's very hard to do those kind of mental calculations about, this thing is really bad. What about these other things that also are problematic? So I think, people had an idea that, yes, learning is not going to be as strong for students, if they're at home versus if they were in person. But they weren't thinking, they're thinking, well, maybe we can make up for that with technology, or we've already put out this technology, and there's so much concern about staff members who teachers and other school staff, and then students interacting with other students, that there's so much concern about people getting COVID and dying that that kind of overshadowed the fact that there are these other negative things happening, and not just learning, but also the fact that you have so much stress on families, issues with, again, the loss of relationships, and also conflict, the increase in conflict at home and in neighborhoods. So it's just very hard for people to balance those things. And there was just a lot of pushback, as much as a lot of people recognized there is this need for, especially for the youngest children, that it was just so hard to do remote learning for the youngest children. This concern that people had about their health and dying, and giving COVID to other loved ones who couldn't be, who were more vulnerable, just completely overshadowed that. And there are different political players, who have different, who are going to be pushing for different things, and so those who thought that schools should stay closed, prevailed.
Thanks, Elaine. We'll move on now to Professor Budish. So Eric, we're going to ask about your research. You've done a fair amount of work in the area of sort of strategy and economic modeling. So the speed of epidemic mitigation efforts, as well as the speed of viral spread, seem to be important variables in the economic modeling you've done. Can you tell us a bit more about what you have found that informs our management of future pandemics?
Yes. So the speed of viral spread, are all familiar with the idea of the reproductive rate, or R naught. R naught for COVID was estimated to be on about 2.5 to 3. So every person who has COVID, if they're acting as if in a society that's taking no precautions, on average would infect 2.5 to 3 people subsequently, and very quickly. So within, on the order of 5 days. So what that means is if you have doubling or tripling of the number of infected every 5 days, by the time a year goes, without any kind of change in behavior, basically everybody gets it. So I think in the kind of simplest epidemiology model, Dr. Landon mentioned the SIR model. Absent any mitigation efforts, there'd be on the order of 200 million infections in the United States, on the order of 2 million deaths. So round numbers, I have exact numbers in the paper. So what I argue, I want to go back to, so the mitigation is reducing R, reducing the spread, the number of subsequent infections from every current infection. And I want to go back to what I think should have been the pandemic response paradigm for COVID. And I wrote as much in a paper I circulated for the first time April 1, 2020, and then in a more elaborate form over the years, recently published. But so let me start with what we should have done, and then we can come back to how the kind of implementation and communications details next. But let me start with what the goal should have been. So I think the goal should have been not to minimize COVID, not to minimize deaths from COVID, and not even to flatten the curve, as I'll get to. I think that was a big messaging mistake, actually. What I think the goal should have been was to maximize social welfare, so social, economic, educational dimensions of well-being, all the good stuff, while treating COVID as a constraint. So while treating R less than 1 as a kind of economic constraint. So what does that mean practically? It means trying to have the best possible society while preventing COVID from growing exponentially. Not minimizing the spread, also not ignoring the disease, but trying to maximize the good stuff, treating R less than 1 as a constraint. So how do you achieve that goal? Well, once you frame the problem this way, and I think the early public health messaging and even the later public health messaging really didn't frame the problem this way, it becomes very clear that you have to think about value and risk of different kinds of activities in the society. So in math, value V, risk R, and the ratio of value to risk for particular activities. So school has really high value, and without any mitigation has high risk, but there are good mitigation technologies to reduce the riskiness of in-person schooling. Crowded bars or nightclubs have much lower value than school, and it's actually really hard to reduce the risk of a crowded nightclub, right? Because the kind of masks, for example, aren't going to be a compelling part of a EDM rave kind of experience. So what do you do? So first you ban stuff with really high risk relative to value. So you ban the indoor nightclubs. There's a famous example from the 1918 flu of the Philadelphia parade.
Yeah.
Don't do that. Ban the stuff with really high risk. Second, use what I call in my research low-cost risk reducers. The public health people use the phrase non-pharmaceutical interventions that lumps together masks with lockdown. A low-cost risk reducer is something that reduces the risk of different kinds of activities, so reduces the likelihood that I spread to the next guy at low cost. It's in the phrase. So face masks, rapid tests, keeping the windows open, these are all ways to lower risk a lot at very low cost to value V. So again, schools are very high value, and they can be made to have very low risk with various kind of low cost risk reducers that I've alluded to: masks, rapid tests, air circulation. Not doing a school-wide assembly. Like there's some stuff you just shouldn't do. School should be a little different, but in-person schooling can be, most of the value can be preserved at much lower risk than if you're not smart about reducing risk. So the important work of our colleague Emily Oster is I think phenomenal on this topic. You don't need masks in all settings, right? So masks in settings like public parks, I think that was a mistake, right? Public parks are not risky in the same way that, this kind of setting, a crowded indoor environment, we should have been wearing masks. In public parks, my kids got shouted down by Chicago police in Lincoln Park. That was a policy mistake. It was not risky for kids to be in public parks during COVID. So where the low-cost risk reducer reduces risk, use it. Where it doesn't reduce risk, don't mandate it. And then the third part of the paradigm I try to articulate in my research is that we also should have been accelerating vaccine development, production, and distribution, essentially to the maximum extent feasible. My co-authors and I called this the world's easiest cost-benefit calculation. So spend billions of dollars to save literally trillions of dollars. So to repeat the paradigm, one is maximize social and economic well-being, including education, subject to R less than 1 as a constraint. Not minimize all risk, not minimize spread of COVID, but also not ignore the disease. You have to maximize the good stuff, treating R less than 1 as a constraint. 2, use low-cost risk reducers and targeted activity bans. So don't do the Philadelphia parade, don't do the crowded nightclub, don't do large in-person conferences with lots of travel. So don't do the super spreader stuff, as ways to get to R less than 1 as efficiently as possible. And then 3, accelerate global vaccination essentially to the maximum extent possible. So let me give you the last, and then I'll stop. Let me put some numbers on what the benefits would have been of getting this right versus, or rather the costs of what we got wrong. So first on the vaccines front. So I worked with a large team of collaborators, including Michael Kramer and Rachel Grennerster and Canis Prendergast here at the University of Chicago and many others elsewhere. And if our work on accelerating vaccine production had been fully acted upon, the US could have been fully vaccinated by March of 2021. And the world fully vaccinated by October 2021. The key idea was to spend money on production capacity while still at risk. So before you know which vaccines are actually going to work, you spend the money anyway. An analogy is if your family's life depends on getting a pizza delivered to your house in the next 30 minutes, you don't order just one pizza, you order all the pizzas and hope that one of them gets to you in the next 30 minutes. And in the meanwhile, second, to get to R less than 1, targeted activity bans on a small set of activities. In my one of the simulations I do in my research, about ballpark 15% of activity or less if there are super spreader kinds of activities you can really target. And because you're targeting the stuff with the lowest value to risk, so really high risk relative to social value, it doesn't actually cost that much economically. It would have cost about 3% of GDP, of social and economic well-being. Again, you're targeting the stuff with the worst value to risk. And then use low-cost risk reducers essentially everywhere where it moves the needle. So yes, face masks at school. Yes, face masks in setting like this one. Yes, rapid tests in both places. Do all the stuff that reduces risk a lot at relatively low cost of value. But don't do the purely symbolic stuff, like mandating masks in the fresh air, which didn't really move the needle on contagion and I think lost some public trust. Relative to actual, this would have saved hundreds of thousands of lives and trillions of dollars. And also, I think, reduced enormous harm to a generation of young people who, as we heard, had a very distorted educational experience for years. I think closing the schools in spring of 2020 made a lot of sense, but by fall of 2020, in-person schooling should have been a universal reality. Let me stop there, and I can answer follow-ups.
Eric, thanks. I'm just going to ask one follow-up question. Just very brief answer would be helpful, just so we can finish off and get to the question and answer. Your risk to value ratio seems like a really wonderful concept. I wonder if that sort of more rational public health perspective would reign the next time something happens, or would sort of worries just about the economy in general, that is, which may be rational, but focus purely on sort of the economy, would those sort of reign as we moved into a pandemic?
I think the messaging would have to be to have an economy, if we got something like COVID. I think COVID demanded a new play in the playbook. It was different from past epidemics, past pandemic threats, and how quickly it spread, where exactly it lived on the contagiousness versus lethality, and the way there was some. I can come back to this in our discussion, but I think the messaging would have had to be we want to have an economy, we want to have education. To get those things, we need to close the bars, we need to close the nightclubs. We need to wear face masks and use rapid tests. Like the first, I didn't actually end up using this title, but the sort of working draft of my paper in like March of 2020 was, could masks and gloves save the economy? And that was back when we thought that COVID spread through surfaces. But the thought was, the idea that you have to lock down the economy to deal with COVID seemed like, and again, for a short period of time, I get it, given all the uncertainty. But it seemed like overreach. The goal was to get to R less than 1, not to get to R of 0. And also, once you start lockdown, you end up carving out exceptions. 40% of the US adult population was an essential worker. Mm-hmm. So rather than having a systematic framework, value and risk, for thinking about what activities we're going to preserve and enhance and what activities we're just going to outright ban because they're too risky, we ended up having this kind of patchwork lobbying amalgam that it was very non-rational, to use your phrase.
Great. Thanks a lot, Eric. We're going to move on now to Professor Levine. So Emma, we know that trust is essential for compliance with medical interventions like vaccinations. And you have shown that even well-intentioned omission of information can undermine trust. So how does this finding from your research impact optimal strategy in a pandemic?
Yeah, thanks for that question. I think it's helpful in answering it to think about what were the competing goals that public health officials had, that communicators typically have, that leads to the withholding or omission of information in the first place. So during COVID, a lot of communicators behaved as if compliance, short-term compliance and reducing worry, those short-term goals were at odds with the long-term goal of kind of establishing and maintaining trust. Right, so that has implications for what we share, how we share it, particularly when we share uncertainty. Right, if you think about uncertainty and you're worried about immediate compliance, you might be tempted to say, well, I'm really confident even if the data proves otherwise. This is what we should do. There's low risk. Listen to me and hope that works. And if you're worried about long-term trust, you'll recognize that you need to be transparent, right, about uncertainty and risks to maintain, right, a perception of integrity long-term. And so, talking to people in public health, someone who worked at the CDC at the time, right, he said that this was the Sophie's choice he faced every day in communication, which is, should I focus on compliance now at the cost of lives later because I could be act certain now, and that will reduce trust in the long run because we know we're uncertain, or should I sacrifice lives now and admit to the uncertainty and hope that buys us lives and trust later? Right, so that's the kind of conflict. And so it's a real conflict, and you're trying to solve this in a well-intentioned way, but when we face these ethical conflicts, we make mistakes. And one of the mistakes is the omission of information. That seems like a reasonable compromise, right? I don't want to lie, I don't want to provide false certainty. I know that will hurt me in time to trust, but I also don't want to be totally transparent about just how uncertain we are at this given time, because now no one will listen. And so maybe it seems reasonable to just kind of wait. I'm going to wait for more information. I'm going to wait for more data. I'm not going to chime in right now. I'm going to be kind of slow. And I'll say that could come from a very well-meaning place. The problem is the audience members, listeners, don't typically make such charitable attributions of that behavior. So when you realize in the public or as an audience member in any domain that someone was hiding information, you lose trust, and you actually judge it much more similarly to just blatant deception, right, than communicators anticipate. And so there's this type of dance that's going on with this perspective gap in terms of how we're evaluating how acceptable it was to omit. And then you combine that with the information ecosystem during COVID and currently, where when there is omission, not only have I lost trust because I'm worried you're, paternalistic, you're hiding information, you're assuming I don't know anything, but now I'm filling in the gaps with alternative information sources that might end up conflicting with what you say later on, and now trust has really been harmed. So I think the second part of the question was, so how does that influence optimal strategy? Well, first, right, we need to be transparent. Not only because we should care about kind of time to and long-term trust, but also because there's a lot of recent research showing that kind of short-term compliance and long-term trust are not as at odds as communicators expect. So there are ways, and there's a lot of nice work in behavioral science going on now, there are ways to communicate uncertainty so that you can still be seen as competent, that people still listen, and trust is not harmed. So that means not saying, I don't know, the situation is evolving, and instead, giving your best estimate and a confidence interval, right? Speaking scientifically with kind of precision and expertise, or a range of probable outcomes, or explaining, this is the evidence we need to kind of resolve some of this uncertainty. I mean, some of those communication tactics can, still maintain trust while also getting people to listen.
Great. Thank you, Emma.
Yeah.
Just to follow up on that real quickly, as I take care of patients as a primary care physician over at the medical center, one of the things that I feel is true is that there's a difference between confidence and trust. And so confidence is about evidence and certainty. And trust is about whether the person that you're speaking to is someone that has integrity and your best interests in mind. And it almost sounds like this is what you're talking about, and maybe you could confirm or deny that.
Yeah, so, I think about trust as a set of perceptions that someone is able, or an entity, an organization, is able or competent, benevolent, has your best intentions in mind, and acts with integrity. And we often do feel that we have to seem confident to inspire trust. And sometimes that's true, but it's kind of confidence in your knowledge, which includes, potentially precision and potentially humility. And so they're not at odds in the way people often expect. And I'll just add, because it relates to something Eric said, I think something public health and communicators also really need to be transparent about is their intentions and their goals, right? Not only kind of the scientific uncertainty, but what were we trying to maximize? Because it's only when that goal is made explicit that you have the leeway to change recommendations along the way, because the means of pursuing that goal may change, but the goal, right, and conveying that it's a benevolent one will really kind of provide some trust infrastructure.
Great, thank you, Emma. So I think I have additional questions for you all, but we'll save them in case we're lacking some questions from the audience, and instead move to the question and answer portion of our presentation. We have some microphones that will be handed out to folks in the audience who have questions. In the meantime, I'm going to be starting with a question that came in advance of the session from someone who signed up as an attendee but could not come in for personal reasons. So the question for our panel is, can you please discuss survivor bias in discussions about COVID in the context of your scholarship or in the context of public health policy and sort of management, and how you would manage that in the work that you do. And just a refresher for all, survivor bias distorts pandemic debates by ignoring those who died or live with long-term effects. So maybe I'll just turn that over to anybody on the panel who'd like to start.
I'll say something about that. I want to say that this is huge, right? Because as a physician, we got to see, Jim knows this too, we saw the people who suffered and died. And as I said in my original answer, people were mad because we couldn't save their loved ones, but people were also mad at me because their loved ones didn't die enough. And they felt like they had made too many sacrifices and it wasn't worth it because it wasn't apocalyptic enough. When in reality, many of those sacrifices that they made were why it wasn't apocalyptic. It's very difficult for people to be grateful for not having colon cancer because you had that colonoscopy. Anybody ever had a colonoscopy? It's not fun. At least the prep part isn't, right? But they take out 4 polyps and that saves your life, but people are still mad that they had to do the prep and they're not excited about doing it the next time. This is the way it is. This is how every person experiences their life. And I think survivor bias is huge here. We were very, very lucky in Chicago because we were a couple weeks behind New York City. New York City had many more deaths, much more hospital disruption. A lot more people died of other conditions because they couldn't get care because hospitals were too full, because they were literally just a couple weeks ahead of us in COVID. They filled the Javits Center with patients. We didn't put a single person into McCormick Center that we set up for an extra hospital, which makes it seem like everybody overreacted, when in reality, it was that overreacting that did it. But I also, in answering this, want to say something else that I think is really important. There is a divide between what public health recommends and what our government officials decide is public policy. To the best of my experience and knowledge, first of all, I agree with absolutely everything Eric said. I would much prefer we did the pandemic that way. We should have done it that way. That was the right thing to do. The pandemic playbooks say you should do non-pharmacologic interventions like reducing the risk from large-scale events and using masks and things like that before you ever try to have shutdowns. We didn't have masks. We were out. There were none. And we couldn't get more because every place in China that made them was closed, and that was the only supply chain we had. We didn't have tests because we didn't scale up our testing. So what was recommended and what was decided on to do were two different things, and yet people like me were asked to go out and defend the policies and the procedures that were recommended. And we had to, because it was better than doing nothing or than the alternative. The options available were not what any of us wanted. And that put us in a really difficult position, I think, as Emma pointed out. You're being asked to defend something that you don't think is the best option, but it's the only option that's reasonable. And so you're kind of stuck. And someone has to explain to people why it's essential for them to do that, and they need to have some authority other than you elected me to help with the economy, therefore I get to tell you that you have to wear a mask. Like, that doesn't make any sense, right? So I think that the survivor bias plays into all of that. Because the people who did well, who didn't suffer, are the ones who are the most mad about having to have worn a mask or not done the things that they wanted to do. And I think that's huge. And it seems to me almost entirely revisionist. Many people say, oh, COVID was never a thing. It was just a hoax. Patients literally come to me for advice on another infectious disease condition and sit in the office and I say, would you like your COVID vaccine? And they're like, oh, COVID's just a hoax. When none of that was real. Nobody ever died of that. And I'm like, are you sure you wanted to come to me? Like,
Thanks, Emily. Other comments from the scholarship side?
Yeah, I mean, I'll just add to that. I mean, right, so survivor bias or survivorship bias is, just a particular form of outcome bias. It could be for, people who had negative experiences as well, right? Think it was the right thing to shut everything down as much as possible, if they lost someone or were close to losing someone. I think, right, that tendency to kind of think what happened to you was always the most likely is precisely why we need really transparent communication about uncertainty. Because if you can have a sense of what is probabilistically possible before it happens, before you experience the outcome, you're better able to kind of interpret that instead of with this revisionist lens.
Can I ask a kind of a follow-up question? Was there an amount of money that could have been spent in March or April of 2020 to accelerate the production of the PPE? So basically to get, because what I didn't hear in the messaging early, and I take your word for it that it was hard that there was a lot of constraints on what the choice set was. But what I didn't hear a lot in the messaging early was, we're going to do stay at home for 4 weeks. Yeah. And then here's the plan after those 4 weeks.
Yeah, I wish it had been said like that.
And then, because what could have been, so the Trump administration made a big mistake not spending a lot of money on PPE, on tests. The Biden administration made a kind of compounded the mistake. They also didn't spend, each administration spent trillions of dollars on various aspects of COVID relief and spent really small portions of that money on actually fighting COVID. Yep. The Trump administration got Operation Warp Speed right. Biden administration got a couple things right, but they got the magnitudes totally wrong. It was spending money on the wrong stuff. And so I guess I wish, I mean, hindsight's 2020, but I guess I wish the public health messaging was more, we're going to do lockdown for 2 to 4 weeks, but then here's the plan afterwards, and here's everything we need the government to do to get us to that, plan.
I want to just say that I think that there were so many constraints about PPE and testing that we couldn't, that's why we lost control of everything. There weren't enough tests. We couldn't even get swabs to do the tests once we had the reagents to do the tests, because all the swabs were made in one town in Italy that was devastated by COVID. Yeah. The supply chains just weren't set up for that. And the federal government, Trump had disbanded a lot of the pandemic preparedness and actually allowed a number of PPE supplies to just expire and then discarded them from strategic national stockpiles right before the pandemic. Which I think most people don't know, that the reason that Anthony Fauci said that we shouldn't wear masks is because because if people went to buy masks, there wouldn't have been masks for healthcare workers. We didn't have masks for healthcare workers as it was. The reason that we did so well at the University of Chicago is because we invested in P100 masks that people use for building with removable filters, which I got a lot of pushback for. People were like, these are not medical certified. You can't do this. I said, I don't care. I want you to spend a bunch of money on them and buy them. And it saved many of our healthcare workers from dying. Yeah. But that was not how most people thought about it. They thought we need only N95 OSHA certified masks, and the only place we can get them is there's no place in the United States that makes them.
So maybe let's move to some audience questions just to make sure we engage them. So I guess on the front here, yes. Please.
And I just want to note, I really appreciate the pragmatism there with the masks. But sort of to that point on pragmatism and maybe bringing in more of the real politics, right, that are going on. And I think this goes mostly to Emily, but you mentioned this flattening the curve, which was about buying time, right? And it seems to justify these mandatory lockdowns, quarantining, and other hardline restrictions of freedom, despite the later harms in education, et cetera, right? So understanding that buying time is necessary against existential threats, you later, regardless, advocated for non-human tracking and the ability to mandate vaccines, et cetera, which leads to faster and more compliant instruments to authoritarianism, which hinders the buying of time against that authoritarianism. So how do you reconcile
that's
this?
a fair criticism. There's no way to do community action without people being required to do stuff they didn't want to do. I prefer for us to do that in a democratic fashion, like for us to vote for people and then agree that this is part of our social contract, instead of just having one person decide for everybody. I know it often felt like during the pandemic, one person was deciding for everybody, but that was never really what was happening. I was making recommendations and elected officials were turning those, and other people were making recommendations and elected officials were turning that into a policy. And I think that short-term mandates of vaccination, where saying you can't return to these places unless you're vaccinated, is not the same as you have to be vaccinated or you can't keep your citizenship. It was a trade-off situation, which no one likes that because it wasn't there before. And so now having to jump through that hoop in order to get something that you were able to achieve without it before is annoying. But I think there's a big difference between saying in order to work here, you have to get tested every week, or in order to work here or go to school here, you have to be vaccinated, or in order to come to this show, you have to be vaccinated, and saying you have to be vaccinated or you just are an outcast. Those are totally different things.
So I'm going to ask our panelists to be sort of concise so we can get to as many questions as possible. Yes, question.
Thank you. I'd like for the panelists, and I think that this is a question for Emma, to talk a little bit about the role of social media and the issue of confidence versus trust. I'm a primary care doctor at the University of Chicago, and one of the things that I noticed during the pandemic was this divide in terms of age, and my patients saying, I'm doing my own research. I have the freedom to do this. I don't trust what's coming forward, and I'm going on social media in order to find out about how I'm going to manage this, versus my older patients, many of whom were here in the time of polio, who were literally burning up the telephone lines to say, when can I come in to get my vaccination?
Yeah, I mean, so this is an ongoing struggle with thinking about, how do we continue to promote access to information while also controlling misinformation? I mean, something that I think is interesting and forgotten in what happened during COVID is a lot of the damage was actually done by truthful information that was nonetheless misrepresentative. So there's a great paper that just came out on this, kind of quantifying the impact of different kind of headlines on Facebook on vaccine hesitancy. And what they find, if you think about impact as both kind of how many people saw it and then how much does it influence hesitancy, what had the biggest negative impact was these true but rare, right, adverse vaccine complications. So I think the number one story was a Chicago Tribune story. That was, the headline was something like, healthy doctor dies 2 weeks after COVID vaccine, CDC investigates. That saw 50 million people saw that, which is like 6 times more than all of the flagged misinformation on Facebook combined, because that stuff got flagged and some of it gets taken down. It kind of censors itself. And so that's really complicated, because that is true. I'd say my best, advice still comes back to kind of transparency, particularly around uncertainty, and helping understand, odds and contextualizing what does it mean that this happened, right? Given what we understand about, the broader priors. But there's a lot being done to look at how to kind of debunk misinformation broadly.
Thanks. The next microphone is, I guess, in the back.
I have it. Yeah. Hi. I think that this was a really great panel. I just wanted to, maybe provide a different kind of perspective than the ones that are represented up here, although it was very diverse. I'm a COVID researcher. I'm a T-cell immunologist who's been studying this for 5 years. And I come from this, I come to this from a very biological perspective. And I think that one thing that's missed with a lot of the policies that we're talking about is a kind of synthesis of the science that has, been generated, the massive amount of scientific research that has been generated to show us that COVID-19 as a virus, or SARS-CoV-2 virus, was not like other viruses.
Nope.
It did not behave like other viruses, it did not transmit like other viruses, and it did not persist like other viruses. And I think that fundamental biology is something that was missing from vaccine design, from policy, and from things like air purification. One of the biggest reasons I still wear a mask is because I've studied long COVID for 5 years. Yep. And I know that people from the ages of 16, personally, 16, who have, never recovered from, post-exertional malaise after COVID, and they, had to drop out of, being recruited by R1, or not R1, I'm sorry, like Division I, track programs because they could never run again the way that they did before, to people in their 20s who, developed new onset Hashimoto's thyroiditis and other autoimmune diseases after COVID-19, not after the vaccine, after the virus. And, now we have a lot of physicians and public health professionals and business professionals and everybody else weighing in to say, hey, this is not that big of a deal. And what I'm concerned about is that it's a massive understudied, overlooked, just time bomb in our population that is going to affect everything from cognition all the way down to the economy. And I think we need to be much more aware of the science when we're forming any of these policy decisions than I think that we have been so far. And just as like the final thing that I'd say about the vaccine, it's true that the vaccine did not cause a lot of adverse events to the extent that people thought that they did. There was like a big misunderstanding. But I think what it didn't do was prevent infection. And if any of us as researchers, as public health professionals, as doctors, we know that the main job of a vaccine is to prevent infection. And what I think the biggest mistake, if I was going to go back, that we all made was that Operation Warp Speed put in all that money into a vaccine that was developed in 3 days. Vaccines take 18 months to develop with rigorous clinical and immunological testing. That is not what happened. Instead, what we have is a subpar vaccine, which was a Band-Aid, to just prevent severe disease instead of prevent infection. And that is why people don't believe that the vaccine works, because they just keep getting infected over and over again. What we should have done in the meantime is to actually develop a better vaccine with better targets, multivalent, et cetera. There are a lot of things that we could talk about, but I just think that that's a
Thank you for your perspective. Any comments on that from the panelists?
I agree. COVID's bad. I literally have I've had to sort of accept the fact that we're just going to have to live with this as a community. Whatever the long-term outcomes are of COVID, we're going to have to deal with them when they show up. There will be some. It's clear to me now, and to most researchers, I'm not a basic science researcher, but I take care of a bazillion patients. I take care of those patients too that still have long COVID. And COVID caused a lot of problems. People are sicker now than they were before. People die more, we have more deaths. You're much more likely to have a heart attack or a stroke in the 6 months after you have COVID, even if you have a really mild case of COVID. Most people don't understand that or know that. More likely to have blood clots. People have all sorts of problems that are related to their COVID. We just don't say, this is probably because you had COVID recently. And we do not respect it as much as we can or as much as we should, period. I still get my vaccines because I want to prevent serious illness, because it seems probably less illness is better than more illness. But yeah, a better vaccine would be ideal. And I recommend, there's pretty clear evidence that Paxlovid prevents, it can reduce the action of the virus in your body. There's more to learn, and cutting off of COVID research funds was not a good idea.
Let me just underscore one quick thing, which is has huge social value to vaccine research, so developing better vaccines, huge social value to pandemic preparedness. These are, when you run the numbers, these are some of the easiest cost-benefit calculations.
We're doing neither now.
Thank you. Thank you, guys. Next question over here.
I had a question. I had a question for the economist.
Yeah.
That's it.
I think that your idea, is, in my opinion, not that unpopular, in the sense that a lot of people think that there could have been a lot of social and economic value that was lost if there were ideal circumstances. But I was just wondering, how would you present this idea to people without being tactless of the idea that maybe people would interpret it as losing lives for economic gain, even though that's not exactly what you're trying to say, but if that's, maybe some people would interpret it as that.
It's an important question. So first, I'm not a comms expert. I'm an economist. I think I'm a good economist and have some intuition about communications, but I'm not a comms guy. I think the way I would have done the communication is, number one, the guiding principle is to have as much social, economic, and educational activity as possible while preventing exponential growth. So that you're right, that's not minimizing COVID. Let me give you some numbers actually just to fix ideas. If society contained R to equal to 1.00, starting from an initial stock of 100,000 infections, which is a pretty reasonable number for an initial stock. It might even be high.
Yeah, I think it's high.
40,000 deaths in the next 12 months. Even R of 1.2, and the flatten the curve diagram was depicting R of like 1.2, 1.3. Let me just pull up the exact.
Yeah, but it's actually higher.
Yes.
R naught turned out to be higher than it was in those original diagrams.
Yeah. So but the flattening of the curve. So getting R down to like 1.3, 1.4, 1 million deaths. The actual realized number of deaths we had in the first 12 months in the United States was about 500,000, which is like an R of 1.15. So we were so close to, we reduced risk by like from 2.5-ish to 1.15, so 55, 60%. If we had gotten to like 60, 65%, we could have saved almost 500,000 lives. So I think the messaging, though, would have, just to answer your question, one is we're trying to maximize the good stuff while preventing exponential growth. So you'd have to really explain to the public in a non-condescending, serious way what exponential growth means. If the curve that no one produced, it's in my paper, but it did not go viral, is if you put I'm flattened the curve as a bad curve, but let me.
It worked. People understood it.
But it was wrong. It was wrong on the sign. It emphasized the wrong goal. It emphasized getting R down to 1.5, 1.2. Here's the curve you should have shown.
I don't think people took it that way.
But here's the curve you should have shown, or not you, but the.
No, it's okay.
So you put R on the horizontal axis, and you put cumulative harm on the vertical axis, and it basically looks like this. So like going from R of 0 to R1, like almost no additional harm. All of the harm comes after as R grows. So I think you could have messaged to the public. It would have taken some non-condescension, some like multiple thoughts in the same communication. But I think you could have communicated that. One could have communicated that, and then also in doing so, communicated. Here's what masks and tests and keeping the windows open and stay home at sick. All of these things are trying to lower the cost of preventing exponential growth. We're just trying to lower the cost of preventing exponential growth, and that helps us keep the economy and helps us keep schools open. And I think the third part of the comm strategy was we're doing everything possible to speed up vaccines and treatments. I think really meaning that. So instead of spending what we spent on Operation Warp Speed, spending 10 or 100 times that. So I don't know if that would have worked, but that's the comm strategy I would have run.
I think it would have been really, really hard with a president telling people to inject bleach, and that the less we test, the less cases we'll have.
That was not helpful.
No.
Okay.
The question I have is, it seemed like the restrictions went on way too long.
Yeah.
And it seems like, in my view, that a combination of maybe public health, but like Fauci and governors in certain states, which violated their own, our governor here was telling everyone to stay home. His kids were in Florida. Should the decisions not be made as much by public health officials, but by people like an economist?
Economists should be in charge. Yes, that's no.
Well, it was being made by me. I didn't get to say when it was over.
It seems the goal, in my view, of the public health is to minimize the health harm, not the overall harm to the United States.
So we're running out of time here, and so maybe just quick responses from the panel, and then we will close the question and answer. Any thoughts on those comments?
I think leaders should have thought about multiple goals at once. So it's not thought about goals. The economy and health, or the social and economy and health, all in the same framework, and that was a failure. A failure of leadership. You mentioned Illinois. Governors in other states have made some bad decisions. There's some governors who made better decisions. But economists are good at thinking about trade-offs and thinking about objectives and constraints. That's our strength. We're not good at, not as scientists. Right? It was a kind of a multidisciplinary new problem. And I think, as I've emphasized, it demanded a new play in the pandemic playbook, and we didn't get it right.
I had the opportunity to get to know the governor a lot during this, and I was never really ever that close with any other political figure before. And I talked to him a lot, and I was shocked by the different things that he had to balance and make decisions about. And I didn't envy that position. But public health wasn't making final decisions about when people got to go back to school or when people got to go back to work, and who got to be an essential worker and who didn't, and when we were going to let restaurants reopen. That stuff was all political. And there were a lot of things that went into that are calculations that are they're more than economic, they're more than public health. I really respect J.B. Pritzker for what he did during the pandemic. I think he cared about people, and his kids were technically stuck in Florida because they were there at the beginning of the pandemic. Yeah. We talked a lot about that. But I just want to say, I think it was really, I think anybody making decisions during the pandemic, it was way harder than you thought it was. And I think anybody who thinks that they could have done a better job making decisions during the pandemic, you should have stood up and done it.
Well, that's a nice way to finish our panel discussion. So in a second, I'm going to turn things over to Tala to sort of close the event. I just wanted to take a moment to thank the Forum for arranging this event. I think it was a wonderful event. I also want to be specific in thanking Tala for the work that she did in helping us be successful with this panel, and also Tom Ginsberg. And then I also personally wanted to thank the panelists for really coming in and spending your personal time talking to this audience. So thank you so much.